Hello, good evening everyone, and welcome to the EUROGEN webinar programme. Just before we get started, I would like to take a few moments to explain a little bit about what a European reference network is. So EUROGEN is one of 24 European reference networks which all cover different medical fields. They were created by the European Commission in 2017. And they all deal with patients with rare diseases or complex conditions. And in our case, we deal with rare urorectogenital conditions that need highly specialised surgery. So the aim for us as a network is to try to deliver faster specialist evaluation and more equitable access to high quality diagnosis, treatment and care for those patients with rare urorectogenital diseases and complex conditions that need highly specialised surgery. And I'm pleased to say that we're now a network of 57 healthcare providers. So all of their specialist teams collaborate together to help improve care for these patients. So just to mention some of our activities, well, within the network, we collaborate using something called the Clinical Patient Management System. This is a new tool given to us and funded by the European Commission, which gives us the ability to conduct European level virtual MDTs between these highly specialised healthcare providers, so that we can give expert advice to any healthcare professional in any hospital that needs it in the EU. We also conduct education and training activities, so like this webinar series, and then we also have a clinical exchange programme. So we have staff moving between our various hospitals, really for knowledge sharing purposes. And we're also working on, it's actually just operational now, we have a EUROGEN registry so that we can collect all the medical data on these patients with the rare diseases and complex conditions. And we know that over time, and we're talking at least a 25-year time span here, that this will give us the knowledge base and the evidence that's so desperately needed for these patients. It's the data that's really lacking at the moment. That's why we're focusing on collecting it. So if you want to know more, please visit our website and please don't hesitate to get in touch with us if you have a tricky case and you would like the collective advice of our experts. We're very happy to do so, and there's no charge for this. It's free to any healthcare professional in the EU, as I mentioned. So without further ado, over to our presenter this evening. So we're enormously grateful again to our experts for giving their time and sharing their knowledge. And tonight's webinar is on the diagnosis workup in male urinary incontinence. And our presenter is Dr. José Medina-Polo, and he's at the Department of Urology in the Hospital Universitario, 12 de Octubre in Madrid. And his main interests are functional urology, urodynamics, and kidney transplantation. So without further ado, over to José's presentation, and do ask questions at the end. Thank you very much.
Hello, good morning to everybody, and welcome to this webinar. As I previously was presenters, I'm José Medina-Polo from Hospital 12 de Octubre in Madrid, Spain, and this webinar is about the diagnosis workup in male urinary incontinence. I don't have a conflict of interest regarding the topic of the webinar. First of all, we had to define urinary incontinence, and to my mind, the best thing to the definition in urology and in functional urology is to go to the ICS glossary. As you can see, we had two definitions: one for urinary incontinence, that is the complaint of involuntary loss of urine, and if we're thinking about a symptom, is involuntary loss of urine experienced during the bladder store phase. So this is what we ask for the patient. If they had loss of urine during the bladder storage phase. Regarding male, there are different causes for urinary incontinence. Maybe the radical prostatectomy is the main cause, but we need to think about other things. For example, the pelvic trauma, adenomectomy, TUR, also a neurogenic bladder, for example, a cerebral stroke, a patient with Parkinson's disease, multiple sclerosis, spinal lesion, and also a patient with bladder dysfunction, for example, overactive bladder, reduced bladder compliance, and those patients with radiotherapy. The first thing that we need to know about patients with urinary incontinence is true that maybe radical prostatectomy is the one that we have in our main, but it's important to know that usually radical prostatectomy produce a stress urinary incontinence, but the most common cause of urinary incontinence is male, is urgency urinary incontinence. It can be related with many things, for example, with the bladder outlet obstruction, also with a calculi in the ureter, patient with overactive bladder. So it's important to evaluate the patient and not only think in a stress urinary incontinence. It's very common that patients come to our clinic referring urgency at urgency urinary incontinence, not related with radical prostatectomy, but our target is mainly to evaluate patients with radical prostatectomy and incontinence. I would like to show this slide about an important series of urinary incontinence after radical prostatectomy. As you can see, the prevalence in the literature is low, 2 to 10%, but the reality is if we go to the clinical practice, we realize that maybe the figures of urinary incontinence is higher. What is the reason? The most important reason is how to evaluate urinary incontinence. No path or one path is the main thing to evaluate, but many patients are adapted to the incontinence and think that there is not a problem to have incontinence. It's important to evaluate. At the end of the presentation, I'm going to give some advice about the evaluation of incontinence. The most important, as maybe the prevalence of urinary incontinence is high, but as you can see, the percentage it decrease over the times. We need to evaluate the patient mainly 12 months after the surgery, but apart that is decreasing the incidence of urinary incontinence, we know that it's estimated that about 4% of the patients with radical prostatectomy require a surgery or other treatment for urinary incontinence. Just some revision of the anatomy of the urethra in the male. We have the proximal urethral sphincter, that is the bladder net, that with treatment, for example, with alpha blocker or with PTUR, we destroy or the sphincter is not functional and there is not effect regarding urinary incontinence. And in patient after the radical prostatectomy, the main thing is a lesion of the distal urethral sphincter that is mainly responsible for the urinary incontinence. As I want to have a very practical webinar, I'm going to directly to the risk factor at the diagnostic workup that the patient needs. First of all, we need to evaluate which patient had a higher risk of urinary incontinence after the radical prostatectomy. This review by Hacker-Sacker, you can see that patient with all age, those passing with operative bladder before surgery, urodynamics findings, for example, problem in the sphincter is a risk factor for urinary incontinence. Moreover, patient with previous prostatic surgery, patient with comorbidities, those with erectile dysfunction that is related also with problem in the neurovascular bundles. those spacing with pelvic floor or vascular problem. And in this point, we can also include some neurologic disorder that can be related with vascular disorder, for example, diabetes, arteriosclerosis, and also those patients with cognitive impairment and thyroid disorder. But it's important to know that patients with problem with cognitive impairment, for example, patients with Parkinson, multiple sclerosis, and in this patient or with all age, it's very important to know that the percentage of patients with urgency incontinence is very, very high. And finally, the surgical factor is important that we had to evaluate the patient properly and had an accurate surgery. Well, we operate the patient, the radical prostatectomy is indicated. We need to know what to do after the surgery. The patient can do our cleaning and we remove the catheter, and we need to give some information. The first thing is to inform about the pelvic floor muscle and to explain how they function. And they need to teach about the training of pelvic floor muscle. It's important that the patient know how abdominal contraction at this time. Recommendation is at least 3 times per day and 15 minutes per session. And if we want the better result, it's important to have a rehabilitation department that can help, and we realize what the result is better, and also the recovery of urinary incontinence is faster. And we need to explain the patient. The patient is maybe worried about urinary incontinence, but we have to say, be patient. The time is working with you, and if you follow the exercise, if you had with a professional in that did a rehabilitation for urinary incontinence, probably you are going to have a better result. As you can see, only 4% of the patient are need to have a surgery or on a treatment after 9 to 1 years. Okay. The revision after the bladder catheter removal, and the second revision, mainly with PSAs, 3 months after the radical prostatectomy. At this point, we had to evaluate not only the urinary incontinence, we need to assess the mixtional flow rate. Why? Because in up to 3% of the cases, we had an stenosis at the bladder urethral anastomosis. If we had urinary incontinence at stenosis in the anastomosis, we need to treat. Usually with endoscopic management is a good option, as we had 50 to 70% of success. But it's important, if the patient is not correctly managed, there is a problem that the consequence can be overactive bladder, urgency urinary incontinence. It can be very difficult to treat. If we rule out an stenosis and the urinary incontinence persists, at this time, I usually give the patient a bladder diary. It's important because the patient can be how the incontinence has the function in the quality of life, and it's an objective way to assess the urinary incontinence. And also, in some cases, medical treatment can be prescribed. For example, duloxetine is off-label prescription. In my clinic, we don't use very often because there are side effects very frequently, and also the result is not very high. But usually, I insist to continue with the rehabilitation. Well, we rule out the stenosis. The patient will proceed with incontinence, and 6 months after the surgery is the time when we start the diagnostic workup. It's the moment when the urologist send the patient to our unit. And what we need to know about urinary incontinence, we have to know the clinical record data. We need to assess urinary incontinence, and we also need additional tests. We are going to review one by one. First of all, regarding the clinical report data, we need to ask about many things. We need to ask about the neurovascular bundle. All the things about the surgery is important. For example, the histology, the Gleason, the stage of the tumor is important to do a recommendation about the urinary incontinence. We also need to know the PCR level before to perform a treatment. We need to ask about erectile dysfunction because sometimes we need to treat both things together. We need to ask about radiotherapy. That is the most important thing. A thing of paramount importance when the patient are referred to our clinics is to know the comorbidities of the patient and what is the expectation of the patient, because there are many patients that are old and that they don't want to go again to the OR for an sphincter or for a sling, and sometimes in this patient it's not necessary to study with urodynamics with cystoscopy. So we need to ask the patient. We need to know what the patient wants. Sometimes if the person is very old with a lot of comorbidity, an option can be to do the clinical story, physical examination. If there are no complications with urinary incontinence, gives pass. But if the patient wants a solution for the urinary incontinence, we need to continue. And the second step is to assess urinary incontinence. We need to ask about lower urinary tract symptoms. We need to ask about the type and severity of incontinence, because not all is stress urinary incontinence. That is the one that we can treat with surgery. In many cases, there are urgency incontinence, and we need to offer drugs or bottles. We need to ask about the number and type of pads that the patient use, and it's important to ask about night incontinence, if the patient is able to stop micturition, and if the patient had positional incontinence. Why? Because if the patient had continence during the night, the patient can stop the micturition. Usually is because the patient had a residual affected of the sphincter. And this is important because usually these patients are the one in which if we use an sling, the sling is going to be good. It's not only the number of pads that the patient use. It's important to know if the patient had a residual sphincter functionality. So it's important to ask if the patient had night continence and if the patient are able to stop micturition. And also we need to ask about previous treatment. Is common, for example, in my department, about 15% of the patient had a previous sling or a previous sphincter when they are referred to our department. Okay, we had the clinical story, and the next step is additional tests. Well, I recommend questionnaires. Is give an objective evaluation of the incontinence, and is important to diagnose it of the type of incontinence and when the patient had incontinence before go to the toilet, when do exercise, and with when is the incontinence. And the best thing about the questionnaires is not only we evaluate the continence before the surgery, we can evaluate the continence after the surgery, and we realize the real prevalence of incontinence that is very is higher in comparison with the study that I presented at the beginning of the webinar. I also recommend the PAS test for all patients, 24-hour PAS test, and I recommend doing the PAS test at least for 3 days. Okay, the PAD test, we can evaluate the number of pads, and there are different classifications about how to evaluate incontinence. We can think about mild incontinence is 1 to 2 pads per day, moderate incontinence is 3 to 5 pads per day, and severe incontinence is more than 6. But the recommendation for the guideline is to evaluate the incontinence with the weight of the path, because it's very different when the patient change the path. There are patients that change the path with one drop than the patient that wait until a path with more than 501. So I recommend to the classification for the PAD test as a mild, less than 100 grams, moderate between 100 and 400, and more than 400, I consider the incontinence severe. This is the PAD test that I use with the patient, was developed with a colleague in my hospital. This is the reason, because it's in Spanish, and the patient evaluate the weight of the past, and usually more than 3 days is recommended. And I ask the patient that do a normal life, because sometimes the patient stay at home and maybe the PAD test is very low, but it's not the reality of the patient. Regarding the other test that maybe you can see in the previous slide, I always recommend cystoscopy and urodynamics for patients with urinary incontinence after a radical prostatectomy, and also in those with radiotherapy without radical prostatectomy. The reasons for the cystoscopy is to rule out stenosis at the bladder net and anastomosis. It's also important the assessment of the prostatic area. It's very important in patients after VTUR, and also in those with radiotherapy, because sometimes we had a very bad prostatic area that this can be a problem if we think it about cesarean. There are patients with calcification, with stenosis, with a prostatic area or the anastomosis, with bleeding, and it's important to do a cystoscopy. Also, the cystoscopy can be some information about the capacity or organic disorder in the bladder. And the most important is to evaluate the construction of the sphincter. But the point is not to ask the patient to contract the sphincter. The point is a repositioning test. We need to press the pyramid, is because if we're thinking about an sling for this patient, we had a positive sphincter coarctation with the repositioning, we think that an sling is a good option for the patient. The cystoscopy with a positive sphincter coarctation after repositioning, and patient with not incontinent during the night, and they can have a positioning incontinent. There are the patients in which recommend an sling. This is the hypothesis about with Dr. Gocci and Peter Weather, that were the inventor of the advance, that they describe when is useful to use the sling. And the reason is because not only the PAD test less than 200 without a negative repositioning test is not good for the patient. And there are some surveys that patients with more than 500 grams with the PAD test, they indicate an advance, and the result is good. In my department, we do everything, and we had into account the PAD test, and usually we recommend the sling in patients with a PAD test less than 300 grams. Well, also, in my opinion, and according to the guideline, the urodynamics are recommended in patients we can debate it is recommended in female with stress urinary incontinence. Yes, there's a debate that can lead more than an hour, but for male, my recommendation is go for the urodynamics, because we can find many things. We can find overactive detrusor, we can find poor compliance in our patient, we need to evaluate the bladder capacity. The stress incontinence is the thing that we expect to find, but in many patients had obstruction. And all these things, the obstruction, operative detrusor, bad compliance, and bad bladder capacity, are factors that are related with poor outcome with the surgery, especially when an sphincter is planning as the solution for the urinary incontinence. And this is the reason because I go for urodynamics, because it's important to inform the patient the result of the surgery. Well, I'm going to introduce two articles about what is important go for the urodynamics. First of all, because not all the urinary incontinence after radical prostatectomy is related with stress urinary incontinence. This is the result of the patient sent to our units with urinary incontinence. At when we evaluate the symptom with questionnaire, as you can see, more than 60% of the patient had overactive bladder. It is true that many patients had only stress urinary incontinence, and the percentage of patients with mixed urinary incontinence is about 25%. When we evaluate urodynamics, as you can see, the percentage of stress urinary incontinence is about 53%, and there are a very high percentage of patients with overactive detrusor, and also there is a high percentage of patients with hypocontractile detrusor and those with decreased accommodation. It's important that we need the cystoscopy for the patient, because the patient had a previous radical prostatectomy. In some cases, the result of the urodynamics are based on the surgery. Maybe the obstruction can be related with the catheter to do the urodynamics, because the bladderness is not so flexible to open to pass the urine, and the percentage of lower urinary tract obstruction with the cystoscopy we realized that was lower. I would like to show this study by Antonella Gianantoni with the group of Elisabetta Costantini. As you can see, the percentage of patients with detrusor operative before the surgery was 61%, and after the surgery was 7%. That there are a high percentage of patients with detrusor operative. The thing is that the urodynamics is an aid to recommend the surgery, and is a way to inform our patient the result of our surgery. Possibly patients with a very reduced bladder capacity, those with very bad compliance, is the person that not recommend urinary sphincter or surgery. But if the patient had a clinical stress urinary incontinence that is not demonstrated in the urodynamics, and the patient had a good bladder capacity and can go, I usually recommend the surgery. Well, this is the recommendation of the guideline that is more or less a summary of what previously discussed. Now we have the recommendation about the management of urinary incontinence in the guidelines about the management of non-neurogenic male lower urinary tract symptom. I took the figure of previous guideline, but as you can see, it's recommended to the PAT test, and we are thinking about to a surgery. It usually recommend to go for evaluation with urodynamic and cystoscopy. we had our patient with a diagnosis, and now it's time to think about the surgery. If the patient had predominantly stress urinary incontinence. At the thing, it's important to have the complete study because we had a lot of options. We had different type of the sphincter. We had adjustable sling as the atoms or the remis, and we also had a fixed sling as the advanced or the virtue slings. And when we choose the treatment for the patient, we had to have in mind different things. First of all, what is the effect of the sling? Some sling, for example, the advanced, the key is that reposition in the urethra. So we need that the patient had a functional sphincter. The atoms combine repositioning and also compression of the urethra. And finally, the sphincter is a mechanism which close or open the urethra. From the sling to the sphincter, the complication is going to increase. We think about prognosis factor, radiotherapy, PSA, possible relapse, if the patient had stenosis, how is the detrusor, and also the ability of the patient. And the most important thing is to manage the expectative of the patient. And it's important to inform about the result of the patient. Let me present. This study is from the EIU, is a revision of the management of urinary stress incontinence, is the Saturn registry for countries in Europe, and my hospital was in the study. As you can see, first of all, there is a difference between the PAT test between patients that go for an artificial sphincter and those who go for an sling. And it's important also that in patients that are cured, the PAT test is not zero. So many patients had urinary incontinence after the surgery, but as you can see, the grants of the PAT test decrease very importantly. As here you can see what is performed in Europe, what is performed in centers of excellence, that is the center that are included in the Saturn register. As you can see, the most common procedure recommended for the management of stress urinary incontinence are the sphincter. And in second place is the advanced sling. Well, but not everything is urinary incontinence. We need to ask a patient for climaturia. What is climaturia? Climaturia is urinary incontinence, but only with the sexual intercourse. And it is described that it can appear with an incidence up to 20% of patients after radical prostatectomy. And climaturia had a treatment. First of all, pelvic floor rehabilitation and also electrical stimulation can be performed, and there are some occlusive rings similar to an sling that had good result in the management of climaturia. Well, the main thing I comment several times during the webinar, that is important a correct evaluation of the patient. The PAT test can be useful to decide between a sling or a sphincter, but the symptom needs to evaluate with a questionnaire. And I recommend reading this study, the master studies carried out in English, that they evaluate the incontinence of the patient with the ECQ questionnaire and with the and the quality of life. As you can see, the patient had an important incontinence and an important interference in quality of life. And when we go for the results of the both male sling or artificial urinary incontinence, if we use a very strict definition of incontinence, the percentage of patients that are dry after the surgery is very low. It's about 15 to 20%. It's true that most of the patients improve the incontinence, and most of the patients are happy with the result of the surgery, but it's necessary go for questionnaire to evaluate the patient and to inform the patient that probably they are going to improve, that it's possible that the patient needs in some activity, but for security, and it's something that we had to inform our patient. And the way that the Saturn study is developed is similar to the master study. Here you can see the result. As you can see, the percentage of patients that never leaks is 13% for an sling and 16% for artificial sphincter. It is true that mainly in all patients the urinary leak is a small amount. Well, let me present the result of our hospital or our department with the patient included in the Saturn study, that we use the ECQ questionnaire and the quality of life questionnaire. We had a sling and artificial urinary sphincter. The urinary continent was in most of the patients very important, in continually or several times a week. As you can see, 1 year after surgery, the urinary incontinence was never or less than 1 per week, and in many cases there was a small quantity. As you can see, there is some patient, about 40%, similar to the master study, that lot with exercise, but there is a percentage that patient that had a loss of urine before reaching the toilet, that it can be related with overactive bladder. The figure is higher in those patients with an sling. Well, finally, the take-home message. We had to ask about manual ability and the cognitive status for the patient. That maybe if the answer is no, not go for an sphincter. In case of radiotherapy, I usually recommend an sphincter, and in some case, anatols. Is we thinking about urethral manipulation, that the anastomosis stenosis is going to reappear again. I usually try to avoid an sphincter. As previously said, if the patient had continence during the night, at the pad test both is less than 300, I usually thinking about an advance, and for thinking about an advance, I usually do a repositioning test in the cystoscopy. And finally, this is our protocol. We evaluate the patient. We use the questionnaire, the bladder diary. We had the diagnosis of straight urinary incontinence. We had a good Department of Rehabilitation. I sent the patient to them, and we don't have improvement in 6 to 9 months. The patient are referred to our functional unit. We also go for a pad test at least 3 days, Urodynamics and Cystoscopy. If the patient had a bladder neck stenosis, we perform an endoscopy surgery. We had during 4 months diameter more than 16 French. We thinking about the treatment of urinary incontinence. If the patient had a urodynamic disorder, we think about medical treatment and evaluate other treatment before surgery. And finally, in patient with a clear straight urinary incontinence, our definition is clinic. We go for a fixed sling with a pad test less than 300. If radiotherapy, usually we recommend an sphincter. In those with a pad test between 300 and 400, we usually repeat the pad test before go for the surgery, and it is confirmed Usually we recommend an adjustable sling, an Atons or a Remis. And finally, in those patients with radiotherapy and good manual ability and a PAT test more than 500, we usually recommend an artificial urinary sphincter. Also, finally, not all urinary incontinence is due to a sphincter dysfunction. As you can see, we usually recommend urodynamics cystoscopy in the diagnosis work up. And something that I need to ask. We need to choose correctly the device, because it's not the same device for all patients. We need to manage all the device, and we need to manage the expectation of the patient. It's important that we need to know how to manage the complication. It's common that those patients that there is a sling failure go for an sphincter, but we need to evaluate that this sling is working good, as currently the gold standard for the management of urinary incontinence is the sphincter, but I think it's going to change very soon, and in selected patients the sling is going to become the gold standard. Thank you very much.
Okay, that concludes the presentation. If anyone has any questions, then please send them through now. I've got a couple through already. If anyone wishes to ask a question over audio, simply raise your hand and I will get around to that. So Jose, I don't know if you can put your camera on. Perfect. I'll just stop sharing the video, sorry.
Hello.
So we've got a couple of questions come through. I'll send them through to you now. Hope you can read them out and then give an answer. That would be brilliant. So I hope you can see those.
Okay, yes, I can answer. The first question is, what are the recommendations for the evaluation of urinary incontinence in male boys and adolescents? Well, the webinar is true that was focused on the urinary incontinence after radical prostatectomy, that we're thinking about stress urinary incontinence, but it is true that the most common type of urinary incontinence is urgency urinary incontinence that can be appear in your male and females. To my mind, and is important to use a bladder diary. It's useful for the diagnosis of urgency, is used to the diagnosis of nicturia. More is the only method to evaluate nicturia, because it's the only way that we can quantify the urine that produce the patient for the night. Is also adequate to evaluate patient that drink a lot of water or other drinks. So I always recommend in patients with urinary incontinence to use a bladder diary, use a three days bladder diary. And regarding the clinical story, is I think that the patient had an stenosis. I go for a cystoscopy or an rake, or is I think that the patient had a neurogenic bladder. Depending on the comorbidities, I go for urodynamics. Okay, the second question is, we all know that duloxetine is not licensed in most European countries for use in stress urinary incontinence. Is there any drug treatment for stress urinary incontinence to be developed? Well, to my mind, to have in a phase 2 or 3 development a drug for stress urinary incontinence, I had no no information to add about any drugs to use in this type of patient. It is true that especially in females there are many studies with laser, with bulking agents that we can use in female are in male is not a drug, and I think that bulking agents can be an option for selected cases. I usually propose in female, usually after a TOT or a TBT. And also the laser can be an alternative to selected patient, especially if the patient had atrophy in the vagina. But the main problem is that the result is usually adequate to say something in patients with moderate incontinence in females. To me, the best thing when the patient had a mild or moderate urinary incontinence is to have a good rehabilitation department and a physiotherapy that can help to the patient to improve, and usually the patient improve faster after the radical prostatectomy. Well, it's not a question, but I mentioned several times during the webinar and I would like to remember the results of the master's study. That, as you can see, there are the percentage of patients with no urinary incontinence after sling or a urinary sphincter, about 20%. And this is important because we need to inform the patient. And I think when we report the result, we need to use a questionnaire more than the PAT test.
Okay, sorry, Jose, we've got no other questions on the typed in yet, but somebody has got their hand raised. So Jakob Mohammed Scare, I know you said thank you to Jose for the presentation. You've also got your hand raised. So if you ask a question, I'm going to unmute you now if you do. So please go ahead. I'm not sure if your audio is working though, to be honest. So. I don't think your microphone seems to be working if you are trying to ask, so apologies. If you have anything to ask, please, I guess type it in as well. Unfortunately, sorry. If anyone else has any questions, please type them in now. We've still got a few minutes left. Just while everybody's thinking about that, I'll just reiterate that, as usual, the webinar has been recorded, and so it will be available to watch again afterwards. We'll send out direct links tomorrow morning probably. It'll be available on our GoToWebinar platform and also on our YouTube channel, where you can find lots of all our other webinars for previous sessions for the last couple of years. So please do register to our YouTube channel if you want to do that, to get notifications of future releases. If you have any questions you think about afterwards, please don't hesitate to send them through to me. You'll have my contact details from the follow-up emails you get. And then I will pass them on to Jose as well for answering.
Yes, I can add a question, because sometimes I speak with the pediatrician, the urologist pediatrician in my hospital, and the difference with the children when I thinking about an sphincter in dens, and the main difference with children is that we have to put the cuff of the sphincter in the bladder neck, so is different, and the procedure is in some cases more challenging. And another difference when we put together the sphincter in a children is that sometimes only with putting the cuff in very young children is enough to put the cuff in the bladder neck. Something to add.
Okay, yeah, thank you, Jose, for that. Okay, yeah, so everybody's got any questions about any of that, please do follow up. The other thing I was going to say, yes, everybody will get a survey after this. If you could fill that in, that would be fantastic. We do read everything that people write and put in there, and we do an analysis of the webinar results every few months to kind of keep on top of how we can improve things and make things better, just in case anything people are finding things not to their liking. So I think, Jakob, you've been asking about a translator French. We should be able to facilitate that or sort that out afterwards. I have another one in my inbox to do as well for that, so I will try and make sure that happens. Okay, I don't think we have any other questions around the topic, so we're kind of approaching 7 o'clock, so I think we can leave it there. So Jose, thank you very, very much for tonight's presentation and taking the questions. Thank you to everyone who joined today. I hope you'll kind of join more of these in the future, and hope everyone has a really good evening, and thank you all very much, and take care.
Thank you, everybody, for the organization or the audience to attend to the meeting.
No problem. Thank you all. Good night.